Since approximately 3 French sizes equals 1 millimeter, and the guide catheter is an 8 French, we calculated that the coronary artery is about 1.5 millimeters larger than the guiding catheter. Therefore, a 4 millimeter balloon is chosen. Predilation is done first, and the distal and then proximal segments of the stenosis are dilated. After the angioplasty, the mid portion of the right coronary artery appears adequately dilated, but there is a small linear dissection distally. The stent is then advanced within the sheath. Contrast injections are made to be certain the stent is positioned properly. The sheath is pulled back, and another angiogram done to be certain that stent position is still adequate and that there has been no movement of the stent in relation to the stenosis. Is the position good? We thought that the position was good, and therefore the stent was deployed, but we were wrong. Post-deployment angiography shows improvement in lumen size, and a high-pressure 4.0 non-compliant balloon was advanced within the stent. After the high-pressure inflation, angiography shows this result. Note that the stent does not cover the most distal portion of the intimal dissection. This indicates the stent was deployed too proximally. What would you do? End the procedure, pass the balloon through the stent and do a distal PTCA, or deploy a second stent through the first stent and distal to it? The only option we had was to deploy a second stent through the first stent distal to it. This would tack down the distal dissection site. The second stent is advanced over the wire guide, which has been left in place. Care is taken, particularly as the stent is passed through the more proximal first stent. The sheath is removed. Contrast injections are made to be certain that the second stent is now positioned just distal to the first stent. We thought that the position was good, and the stent was deployed. After the second angiogram, there's improvement in the appearance of the coronary artery distal to the first stent. Attention is now turned to the residual dissection proximal to the first stent and the more proximal right coronary artery. Now what would you do? A third stent? Quit? Do a PTCA? A third stent placement is indicated proximal to the first stent to deal with the proximal residual dissection. The third stent is advanced and the sheath removed. Pre-deployment angiography shows the position to be excellent. The stent is deployed, and the deploying balloon is then deflated and removed. Angiography shows the proximal segment to be free of evidence of dissection. There is still a slight step down distally at the junction of the most distal stent and the native coronary artery. The artery appears to be well treated. What is the next step? Quit, use a high-pressure non-compliant balloon in all the stents, or place a fourth stent? A high-pressure non-compliant balloon should be used to fully expand all of the stents. The high-pressure non-compliant balloon is advanced through all 3 stents and inflated throughout the area of stenting. Final angiography shows no evidence of dissection in the proximal and mid portion of the right coronary artery. There is still a slight step down at the distal end of the stent into the native coronary artery. Case 6 is a 73-year-old man. He had a dominant right coronary artery with a calcified osteostenosis, an ejection fraction of 60%, and there was non-obstructive left coronary system disease. Right coronary angiography shows a tight calcified osteostenosis. Which strategy would you pick? Stent, rotoblator, PDCA, or atherectomy? We chose the rotoblator because of the calcification and osteal position of this lesion. A 14 thousandths high torque floppy guide wire is first advanced down the right coronary artery. It initially is deflected away from the right coronary orifice by the calcified osteostenosis. A second attempt places the tip of the wire guide in the right coronary artery and through the stenosis. Care is taken to be certain that the wire guide is not in a side branch of the right coronary. The tip of the guide wire is in the right coronary artery past the osteostenosis. Is this position adequate? No. Although the tip of the guide wire is in the mid portion of the right coronary artery, it should be further down the artery to give maximum support to the rotoblator. A few moments spent at this point to advance the tip of the wire guide into the distal right coronary artery is invaluable for outcome success. With care, the wire guide is advanced until its tip lies in the posterior left ventricular branch of the right coronary artery. The first rotoblator burr, which is 1.5 millimeters in diameter, is advanced across the osteostenosis. Note the difficulty with which a smooth, slow passage is completed. After the angiogram, there seems to be little improvement in the degree of stenosis. A 2.0 millimeter burr is then used. Multiple passes are made, and this time the passage is smoother and can be made more slowly. Angiography now shows improvement in the proximal calcified stenosis. What is the next step? Place a stent in the right coronary orifice, do nothing further, do a PTCA of the right coronary orifice. We chose to finish up with a balloon angioplasty of the right coronary orifice. Nitroglycerin is given down the guiding catheter, and a PTCA is then performed using a 4.0 millimeter balloon. Final angiography shows an excellent result. Case number 7 is a 52-year-old woman. She had 3 months of progressive angina despite medical treatment. She continues to smoke despite angina and has hypertension and hypercholesterolemia. She has recent rest angina. Right coronary angiography shows an 80% mid-right stenosis. Which strategy would you choose this time? Stent, rotoblator, PDCA, or atherectomy? We chose PDCA in hopes that the minimal intervention would be successful. A wire guide is advanced down the right coronary and then across the stenosis. A 2.5 millimeter dilating balloon catheter is advanced over the wire guide, but there is difficulty in traversing the lesion. Angiography shows the balloon still proximal to the stenotic segment. With deeper intubation of the guiding catheter, the balloon catheter is finally advanced across the stenosis and the position appears good. The balloon is inflated. Angiography after removal of the balloon shows an irregular result with some residual stenosis. What would you do now? Abandon the procedure? Stent the mid-right coronary artery segment? Rotablator? Or a larger balloon PTCA? We chose a larger perfusion balloon and a long inflation. Final angiography shows improvement in the area of stenosis, but still some residual irregularity, which we chose to ignore. Case 8 is a 65-year-old man. He is an insulin-dependent diabetic. He was a smoker. He had COPD and a recent increase in exertional dyspnea associated with angina. His stress thallium shows inferior redistribution. Right coronary angiography shows a mid-right irregular stenosis. What strategy would you choose to treat this lesion? Stent, rotablator, PTCA, or atherectomy? We chose to stent this lesion because it was not calcified and relatively discreet. The size of the pre-dilating balloon is important here. The guiding catheter is 8 French. What is the appropriate balloon size? We actually chose a 3.75 millimeter balloon. A 14 thousandths inch high torque floppy guide wire is first advanced across the stenosis. The pre-dilating balloon is advanced over the wire guide once the distal tip of the guide is in position. Contrast is injected to be certain of correct positioning. Predilation is then done with a 3.75 millimeter balloon. There is improvement in stenosis, but still some eccentric irregularity. What size stent would you choose? A 4 millimeter stent was chosen. The stent is deployed within the stenotic segment. After stent deployment, a high pressure, non-compliant balloon is inflated within the stent. Final angiography shows an excellent result. To evaluate appropriate deployment of the stent, intravascular ultrasound was used. The lumen within the distal portion of the stent was measured at 3.2 millimeters. The lumen in the proximal portion of the stent was measured at 3.3 millimeters. As the IVUS is withdrawn, note that the area proximal to the stent is widely patent. Case 9 is a 77-year-old woman. She has had 3 days of severe chest discomfort ending with an acute inferior myocardial infarction associated with third-degree AV block. She was treated with streptokinase and has been pain-free since. The CAS shows diffuse right coronary calcification, and on this angiogram, a tight osteostenosis is seen. What strategy would you select this time? Stent, rotablator, PDCA, or atherectomy? We chose rotablator because this is an osteostenosis. The wire guide is not easily advanced into the distal right coronary artery. It appears to be hung up in the mid portion of the artery. What is the next step? Abandon the procedure, send the patient to surgery, use a stiffer wire, or use a tracker catheter for support? We chose a tracker catheter. In order to give more support to the wire guide and allow easier advancement into the distal artery, we advanced the tracker catheter until its tip was in the proximal right coronary artery. The wire guide can then be advanced to a more distal position. Once the wire guide is appropriately placed, the tracker catheter is removed and a 1.75 millimeter rotablator burr is advanced through the osteostenosis. Multiple passes are performed. The patient experiences chest pain, which becomes severe, and the electrocardiogram is shown. What would you do? Call the surgeons, give morphine and Inderal, give intracoronary nitroglycerin, or insert an intra-aortic balloon pump. Intracoronary nitroglycerin is given and the pain subsides. The burr is then advanced across the stenosis again. The original burr is replaced with a 2.25 millimeter burr because there does not seem to be adequate relief of osteostenosis using the smaller burr. With use of the larger burr, chest pain recurs associated with hypotension. What would you do? Call the surgeons back, give morphine and Inderal, give intracoronary nitroglycerin, or insert an intra-aortic balloon pump. 100 micrograms of nitroglycerin is given through the guiding catheter. 2 minutes later, the electrocardiogram is improved and the blood pressure is stabilized. A right coronary angiogram, however, shows a radiolucency in the mid-portion of the right coronary. There is no chest pain, and the patient is stable. What is the next step? Surgery, intercoronary urokinase, PTCA, further rotablator therapy, or remove the wire? We were not sure what caused the radiolucency. It could have been an artifact caused by straightening of the artery due to the stiff wire, or it could have been a filling defect. We chose, therefore, to do a PTCA of that area using a 2.5 millimeter balloon catheter. Final angiography with a wire guide still in place still shows some residual radiolucency. However, when the wire guide is removed, the lucency disappears. This is a pseudo-lesion caused by the wire guide straightening the coronary artery. The last case is a 73-year-old man. He had a PTCA done 8 years ago. He has had 1 month of recurrent angina. He has anteroapical ST segment depression with pain, and the angiogram shows left coronary artery calcification. As you can see, the proximal LAD has a tight calcified stenosis just after the takeoff from the main. The guide is 10 French. What strategy would you use to treat this lesion? We first chose atherectomy, but were unable to pass the device through the lesion, and therefore, as a second choice, we chose to stent this lesion after predilating with a 4.0 non-compliant balloon. The post-dilation angiogram shows a cap dissection in the area of the lesion. The stent is advanced and carefully positioned and deployed. A high-pressure 4 millimeter balloon is inflated within the stent, and the final angiogram shows a good result. The patient was returned to the CCU, and an electrocardiogram was taken post-stent. The electrocardiogram is essentially normal. 5 hours later, the patient developed progressive hypotension and tachycardia. He had no chest pain. Fluids and atropine were given. There was no clinical change. An electrocardiogram was repeated. The electrocardiogram remains virtually unchanged. There is no evidence of injury or ischemia. What is your diagnosis? Retroperitoneal hemorrhage, pericardial tamponade, GI bleeding, thrombostent, or simply a vagal episode? With hypotension and tachycardia without ECG changes, bleeding or tamponade are most likely. What is the next step? An abdominal CT, cardiac echo, endoscopy, or more atropine? An abdominal CT and cardiac echo were both ordered. The abdominal CT was done first, and it showed no evidence of retroperitoneal hemorrhage. However, it did show evidence of pericardial fluid. What is the next step? Emergency surgery, emergency pericardiocentesis, give pressors in volume, urgent catheterization. We gave pressors in volume and then did an emergency pericardiocentesis. 500 cc's of non-clotting blood were removed from the pericardial space, and the hemodynamics promptly returned to normal. There was no further bleeding, and the patient was discharged 48 hours later. We assume that there was a small coronary perforation at the stent site which sealed spontaneously. Thanks for working through these cases with me. I look forward to seeing you at our Heart House program in the future.
To the frame for the roof system. We're still waiting for some part of the construction to come along where things move along as quickly as we'd like them to. Well, it didn't happen with the excavation since we were fighting rain all fall, and it didn't happen with the foundation with the 50 or so corners. Maybe it'll happen with the framing. Anyway, Dean's inside talking to Chris Jordan, who's our lead carpenter, trying to get a handle on our schedule.
Now, obviously, these two roofs here get trusses. Is this whole area going to be trusses, or?
Everything from where we're standing right here to the end of the house is stick frame.
Okay, how about the front entry area here?
Front entry is hand framed as well.
Okay, but trusses over the great room here then?
That's right. The great room is all truss built, and then everything over the breakfast room, the kitchen, and the dining room are truss built.
So this should be pretty straightforward then, don't you think? Maybe not.
Not quite. It's I counted 54 facets to this roof the other day.
Okay, so and a facet being what?
A roof plane. I mean, each individual piece isn't all that difficult, but there are a whole lot of little pieces going together here.
When do you think we're going to be able to start putting windows in?
Well, it'll only take us a couple of days to hand frame the trusses, but then we have to go back and detail the thing out. We have to set soffit and fascia, do the dormers. We're probably looking at about a month altogether before the roof is completely done.
Okay, so about 4 weeks we can start setting a few then.
We'll have paper on the thing. We can set windows in about 4 weeks. That's right.
Okay, well, fair enough. I'll let you get back at it here.
Good enough.
Thanks.
We could use a little more help.
Well, like Rob and I up here?
Yeah, right.
We'll take it under consideration, all right?
Good enough, thanks.
Well, today they've gotten to the point where the roof framing and the sheathing are almost done. So the overall massing of the house is finally starting to take shape. Well, it's been about 9 weeks since the first truss showed up to get to this point. And as always, the hand framing was the most time-consuming and labor-intensive part of the job. You may remember that we've been using a couple types of engineered lumber for our floor systems. Well, we're using the same sort of materials for our roof structure. We're using laminated veneer lumber for the ridge beams and any place else where we need to carry some pretty heavy loads. And we're using engineered wood I-beams for the rafters themselves. One of the toughest parts of hand framing roofing is hoisting up the rafters, and the wood I-beams are about half the weight of comparable dimensional lumber. So it's a lot easier on the carpenters. And as high-quality dimensional lumber gets more expensive, these engineered wood products get more cost-effective. They've been putting on the roof sheathing as they go. It's a half-inch thick oriented strand board. We're using more and more OSB products. One advantage of this type of product is that it doesn't take large trees to produce it. Small pieces of almost any type of wood are glued and fused together to make the sheets.
Another product you possibly haven't seen is this wall sheathing. I realize most of the exterior walls are the poly steel, but in areas that we had to frame up, like around this window, we use the sheathing. Now, this is actually made up of recycled newspaper and gypsum. It's about 25% newspaper. If you could feel this, it's a very dense material. Should definitely cut down on noise in the house. Well, definitely at this stage of the construction, you can finally stand back now and get a much better idea of what the whole house is all about, at least from the outside. And rather than have me stand here and lecture about why we think this home has a lot of character, let's catch up on a tour that we took with the lead architect for this project, Dan Knapp. Well, you know, one thing is when people first pull up here, I think their initial impression is this place is huge, but you know, really the footprint isn't that large.
No, that's right. And things are going to change about the scale of the house, too, here. Once all the grade gets up to the house, that's going to change it. And once all the landscape goes in, that's going to cut the scale of the house, too.
When we get the stone wall around the front here, too, I think that'll help just bring the thing down a little bit.
That's right. But remember here now, though, too, is that although we didn't want the house to look ostentatious, we also didn't want it to look too small because we had that great big neighbor over here. You know, we had to raise the house up a little bit to kind of compete with that.
Yeah, no, it's a balance between, you don't want it too small looking, but at the same time, we don't want baronial either.
No, that's right.
Well, definitely starting to dry up out here a little bit. Makes it easier to get around.
Yeah.
But you know, one thing, now that it's getting framed up, you can definitely see there's some symmetry here, you know, based on what we were talking about in the plan. At least along the roof lines, you can see the symmetry on either side.
Yeah, now you can see how the form is starting to relate to what we did with the plan here. but it's also not, you know, statically symmetrical.
What do you mean statically symmetrical?
Well, over here in the master bedroom, these windows over here are not going to want to be the same as we have over here in the eating area. Their programs are different for each space.
So in other words, if you have, let's say, a bed in the bedroom there and you want a window in front of that, you don't have to move it over 4 feet just because that's where the window goes in the kitchen
That's
area.
right. The other thing we're trying to do here is to try to create a mass with the house, a general image to the house that the mind can understand and is enjoyable, but at the same time, with that simplicity of the overall mass, we want to have the eye allow it to wander over all these little different items that are going on us.
So you want it to be a little different. In other words, you wouldn't want to just take that master bedroom form there and just reduplicate it onto that side.
Yeah,
it'd be a little boring.
It'd be a little boring, you're right.
Okay.
And you can see lastly here that even each roof is not symmetrical. If those were symmetrical, it'd be the same type of thing. But here, because it's asymmetrical but it's balanced by the other one on the other side, we don't create chaos out of the situation.
See, Dan, I don't think I told you this, but when we first started building this, we started with the garage first, if you remember. People would pull up and they'd say, boy, that's a nice looking house you guys are building. They actually thought the garage was the house.
Oh, yeah.
I thought that was interesting.
That's the trouble with these big garages now. You know, historically, they didn't have this. There was either a carriage house that was detached or it was a very small little garage attached to the house. We didn't have to have this kind of problem. Remember here, trying to get this traditional image, we tried to tuck this garage underneath in the basement so you can see it, or drive around the back and kind of hunker it down.
And we didn't want to do that. I mean, our idea was let's pull up in front of the house, let's be able to experience this expensive home we're paying for, and this way you have the option too of going through the front door or the mudroom. You don't have to go around the back like some service quarters or something.
And that's a good point. So we changed our concept of how we're going to deal with this garage here. You know, we didn't want to put it up by the front door yet and still have it compete with the house in general. But instead here we wanted to come in the driveway here and look right on axis with the front door. So your general image is of the house and not of the garage. So you see that, and then we put the garage over here on the side as far as we could, so it's part of your peripheral vision. It's still part of the whole overall concept of the house and of the general image, but it's not your first impression.
Well, it's always interesting to get the perspective of the architect that actually created the plan, so it's always kind of fun to have Dan out here and just kind of pick his thoughts.
Is he still there?
Yeah, right over there.
Oh.
Can you see him?
Yeah, I can. I'm zoomed all the way in.
Oh, we had kind of a different thing happen here today. There's a bald eagle out on the edge of the ice here on the lake. Is he eating something?
Yeah, fish maybe.
Huh. I like that. Half nature show, half home improvement. Well, at any rate, on next week's program, we're going to start working a lot more on the exterior. We're going to start on some of the finishing materials.